Welcome to The Explainer. Today, we're diving into a really crucial clinical challenge: how to effectively diagnose secondary obesity. We're going to lay out a practical framework, a kind of mental roadmap, to help figure out which patients need that deeper investigation.
Right, so we're all familiar with the big numbers. Something like 2/3 of adults in the US are dealing with overweight or obesity. And yes, for most of them, it's primary obesity, that complex mix of genetics and our environment. But here's the question that should really be on our radar as clinicians. Tucked away inside that huge number is a small but incredibly important group. A group where obesity isn't the main issue, but a symptom of something else, something we can often treat. And, well, our job is to find them. To do that, we're going to treat this like a real clinical investigation. Think of it as a diagnostic funnel. We'll start broad, looking at the common endocrine causes. Then we'll narrow things down, focusing on the red flags for rarer genetic conditions. And finally, and this is the exciting part, we'll see how getting that diagnosis right connects to a whole new world of targeted therapies. Okay, let's dive in. So just to be clear, our focus today isn't on the majority. We're zeroing in on that critical minority where a single specific disease is actually what's driving the weight gain. And this right here, this is the whole point. The goal isn't to just order a battery of tests for every single patient. No way. It's about sharpening our clinical instincts to know when it's time to dig deeper. And that's exactly what this explainer is designed to do: give you a clear, evidence-based path for that workup. All right, let's start at the top of our funnel, the widest part, the endocrine workup. These are going to be the most common secondary causes you'll run into. And we'll use the fantastic clinical practice guidelines from the European Society of Endocrinology to guide us. And the main message from the ESE is really a call for a change in thinking. They're telling us to move away from routine scattershot screening. The recommendation is crystal clear. We need to do targeted testing, and that testing should be driven by specific clinical signs, not just by the presence of obesity itself. This table just illustrates that point perfectly. Let's take a look. You see, hypothyroidism has a prevalence of about 14% in this population. So while we're not treating it just for weight loss, checking thyroid function makes sense. It's common, it can make things worse. But now contrast that with hypercortisolism, Cushing syndrome, which has a prevalence under 1%. For that, the guidelines are telling us to be extremely selective. Only tests when the clinical picture is really pointing you in that direction. And this is where the art of clinical medicine really comes in. This slide just nails the high-yield clues for telling Cushing's apart from simple obesity. You have to look for the catabolic effects of all that excess cortisol. Simple obesity doesn't give you weak proximal muscles or thin skin that bruises if you just look at it wrong. And in kids, this is a huge one. Weight gain with slowed growth is a massive red flag for Cushing's. It's the complete opposite of what we usually see in primary childhood obesity, which is often accelerated growth. Okay, so what happens when that first endocrine workup comes back negative? But, your gut is telling you something's still not right. The patient's phenotype just doesn't seem to fit with primary obesity. Well, that's when we have to go deeper into our diagnostic funnel. And this is where we start applying that second, finer filter. We're now on the hunt for very specific patterns, a whole constellation of symptoms that might suggest a rarer genetic condition is at play. These are the signs that should really make your ears prick up. It's usually not just one thing, but the whole picture. Severe obesity kicking in during the first few years of life, combined with that absolutely insatiable, distressing hunger, hyperphagia, or developmental delays, or certain physical findings. Any of these should make you think beyond a simple diagnosis. Now, here's a category that's key to consider, and it's a real paradox: the lipodystrophy syndromes. The problem here isn't too much fat. It's actually a profound pathological lack of healthy fat tissue in certain parts of the body. And that leads to fat being stored where it shouldn't be, causing all sorts of severe metabolic problems. And for these conditions, the physical exam is absolutely everything. The visual pattern of fat loss is your number one clue. Is the fat loss total, generalized, and there from birth? That might suggest CGL. Or is it partial, maybe starting around puberty? That points you more towards FPLD. That initial observation on exam, it guides the whole rest of the workup. This kind of structured approach is what makes a really complex diagnosis feel manageable. You move step by step. You start with your observation, you rule out other things, you classify the pattern of fat loss, and then you figure out if it's likely genetic or something acquired. It's a clear path forward. Okay, so we've identified the red flags. Now, let's just do a quick tour of a few of the key conditions you might see, and we'll focus on the patterns that help you tell them apart. The name of the game here is pattern recognition. For Prader-Willi, the history is just classic, right? That shift from being a floppy baby who struggles to feed to a child with that intense, driving hyperphagia. For Bardet-Biedl, you have to look beyond the obesity. It's a ciliopathy, so you're looking for things like retinal dystrophy or kidney problems. And then MC4R deficiency is interesting because it often presents as just severe obesity and hyperphagia, but without all those other complex features. And even within MC4R deficiency, there's a spectrum. If a patient is heterozygous, carrying one mutated copy, it's actually the most common cause of monogenic obesity we know of, found in about 2 to 3% of people with severe obesity. But the clinical picture can be pretty variable. On the other hand, if they're homozygous with 2 bad copies, that's extremely rare. But it causes a complete shutdown of that pathway, leading to a much more severe and consistent phenotype. All right, let's bring this all home. Why are we talking about this? Why does this deep diagnostic dive matter more today than ever before? Well, it's because for the first time, we have targeted mechanism-based therapies actually coming out. And this is where diagnosis meets real opportunity. For patients with generalized lipodystrophy, we now have metroleptin. For those with defects in that leptin-melanocortin pathway, like POMC deficiency, we have MC4R agonists, like setmelanotide, that can actually bypass the problem and restore satiety signals. We are finally moving from just managing complications to actually treating the underlying disease. It's a huge deal. So if you take one thing away from all this, let it be this. Becoming a master at diagnosing these conditions isn't about ordering every test under the sun. It's about having a structured approach, that diagnostic funnel, and training your eye to see the patterns. It's about moving from broad screening to being a sharp clinical detective. That is your most powerful tool. And that leaves us with a really fascinating question for the future, doesn't it? As genetic testing gets cheaper and more common, we're going to be able to map out the genetic risks for so many more of our patients. So how is that going to change how we even classify obesity? Is that line between polygenic and syndromic going to get blurry? And more importantly, how is it going to change how we treat them? It's a space we'll all be watching very closely. Thanks for joining me.